Very good afternoon to all of you. We will start our session. May I request Dr. Subhabrata ma'am, Dr. Rajinder Kaur sir, anybody please present come to the chair. Srinivas Joshi sir. Okay, so we will start our session. Our first talk is by Dr. Piyush Bansal. It's surgical pearls for macular hole surgery.
याद तो नहीं मुझे लगा याद नहीं मुझे लगा Good afternoon everyone. So I'll just be quickly showing some case scenarios and hopefully some pearls for macular hole surgery. As we all know, the primary management for macular hole treatment is essentially a vitrectomy with ILM peeling with internal tamponade. Tamponade may change depending on how big the hole is, or perhaps not even a tamponade. So this is incidentally the first macular hole surgery that I had done maybe a decade ago. As you can see that the technique is comparatively old. It's an older video where I'm going across the macula with the ILM peeling after the vitrectomy, of course. And by and large, we've stopped doing using that technique now. What we do is just similar to cataract surgeons, where they do a capsular excess. We can do a peel all around the macula. As you can see, it's being done with an ILM forceps over here, and then try to extend the peel as much as possible easily. Of course, it's not mandatory to go from arcade to arcade. What is important is having a good area of clearance around the macula, maybe around 200-300 microns or so. Again, this technique can be used for smaller holes, but for larger holes, we've pretty much shifted to inverted flaps, wherein we leave some amount of the ILM attached to the whole edge. As you can see over here, the peeling has been initiated superiorly, and then it's going on inferiorly, and then again start again superiorly on the other in the other circumference. So this essentially is a 180 degrees type of peel, but you can also do a cauliflower kind of peel, wherein you have multiple leaflets. So again, you see there's a residual ILM flap that is kept over the macular hole. It's never to be stuffed inside. We don't want to damage the RP. We don't want to unnecessarily cause reduction in visual potential. So following that, you can extend the area of the peel as much as possible. In a traumatic macular hole, the peeling can be comparatively easier because the ILM is slightly loose over here. As you can see, it's a punch down kind of a hole. However, in these kind of cases, it's important to make sure that you have a good PVD induction, because PVD induction in these patients is comparatively more difficult as compared to routine. And again, I don't use diamond dusted forceps, or I don't use finesse loops that often. Finesse loops sometimes in difficult cases, especially when it's it's a longer eyeball. Otherwise, I prefer using the ILM forceps, as you can see over here, and then gradually pinching and peeling, not being too aggressive, and then making sure that you don't lose your flap over here, because in traumatic cases, you can always end up with surprises. So it's a large hole, of course, so you require a larger, a definite inverted flap, and I like to trim the flaps. I don't like to have too much of ILM over there, because what happens is during fluid air exchange, the chances of the flap moving out of place is higher. Now, this is a macular hole with a retinal detachment, of course, with a separate retinal break. So you treat it as a macular hole and a retinal detachment case, and after doing a vitrectomy, what is being done over here is base shaving, and then making sure that all the vitreous near the retinal break is removed. It's very important to remove all vitreous, just like a routine retinal detachment. It's important to remove the vitreous attached close to the break, and making sure that there's no residual traction, otherwise you'll end up with a recurrent retinal detachment. And after this is done, the focus is moved to the macular hole. As you can see, it's despite doing fluid air exchange, the retina was still it's embolus. So in that situation, I preferred using a PFCL bubble. You can use a larger PFCL bubble also to flatten the retina and then peel the ILM underneath the PFCL bubble. And what I am using it essentially is to give some amount of counter traction. Now you can see that there's a nice area of ILM peel around the macular hole, and then the attention is taken back to the break, do a fluid air exchange, and make sure that the retina is on. After this is done, the next step would be, of course, to do endolaser all around the break. Now, I don't prefer to do a 360 degrees laser, especially making sure that if one is, of course, not sure of other lattices, other areas of breaks, then you can do a 360 degrees laser, otherwise target it only around the retinal breaks. And of course, these cases require silicone oil. You can't get away with gas in these kind of cases. Now what I've done is I've moved away from using PFCL and just macular hole RDs. As you can see over here, there's no PFCL, and the ILM peeling is being done in a detached retina. And it's not that difficult with patients and a slight more experience. One can do it. It's a large hole that you see over here. So the plan is to have an inverted flap over here. So the chances of hole closure are higher. Now, what is important is, again, not to stuff it. And second important point is never to drain fluid from the macular hole. Create a separate retinotomy and then drain the subretinal fluid, as you can see being done over here, following which do a fluid air exchange. Now, this is a video by my senior colleague, Dr. Rupakanti Biswas from Kolkata, wherein in a failed macular hole, what he does is, if there's no ILM that he can really see, he takes a retinal autograft using a trephine. In this case, it was a 550 microns trephine. And then lifting up the refined retina and then making sure that the orientation of the piece is maintained, and then under air placing it at the macular hole. Now, visual prognosis in these kind of cases is, of course, not as good as your primary macular hole surgeries, but yes, you can achieve anatomical closure, and some amount of visual improvement can be expected. But again, it's following which you do a fluid air exchange. Thank you very much.
Thank you, sir, for this very nice demonstration. I have two questions for you. Sir, do you have any experience with air only?
Can you repeat, ma'am? Sorry.
Do you have experience with air only tamponade?
Yes. Yes. For smaller holes, patients who are diligent with their, of course, I don't have intraoperative OCT. Otherwise, what I would like to do is check it over there and then maybe keep the patient for some time. We discharge our patients anyways. Most of the hole closures in the smaller ones is generally achieved in a day. So if you can call those patients again and see, you can even stop your positioning. And depending on your surgery, I mean your experience, you can definitely use just air for tamponade. We've reduced the concentration, the amount of SF6 or C3F8 that we use also. So air is definitely being used. But for larger holes, I still prefer expansile gases.
Second is, you must have some series of cases with this autologous transplant. Visual outcome, how much it is
so I have no
significant from not doing surgery or non-closure, then transplant?
Yes, so I have zero experience with autologous transplant. That is my senior colleague's case, but he has quite a few patients now that he has done, and his visual prognosis is, again, some patients did improve to the tune of 660 or 200, but not every patient improves. The chances of the prognosis is better, like I said, with primary macular holes.
In inverted flap, you prefer a single flap closure or
I prefer signal. There are multiple techniques out there. In fact, the most recent one is people are doing a temporal flap and just peeling temporally. Some people use multiple flaps placed over each other. Again, I don't see the need for all of that, but temporal flap, yes, but not multiple flaps.
But if resurgery is required, you prefer from which area you usually take other initial flap dislocated?
Again, a free flap is also being done. The free flap is generally taken from the nasal retina. Again, I have not done free flaps too many times, just a few cases. We've achieved hole closure in, I think, in 4 out of 5. The 5th one, I think, was lost to follow-up. So again, there are multiple techniques.
Thank you once again for this nice presentation and nice
You.
demonstration. We will move to our next talk. Dr. Srinivas Joshi, I think he is not here. Next, Dr. Kusumita Chowdhury, is she present? Okay, she is also not here. Then Dr. Bikram Binayak, gene therapy for AMD. No. Okay. Next is Dr. Bandana Akshay Iyer. She will discuss retinal detachment surgery, tips and tricks for the beginners.
Any audio? Audio is not?
ऑडियो नहीं है, ऑडियो नो ऑडियो। Yeah. Good afternoon, everyone. I am Dr. Vandana Iyer from AIIMS Nagpur. I'd like to thank AIOS for giving me this opportunity to present this in this faculty talk. My topic is retinal detachment surgery, tips and tricks for beginners. So first and foremost thing is to choose the right case. So see, as we have just finished our fellowship, we would be at different skill levels. So it's very important to assess yourself, see your comfort zone, and take cases initially which the ones you are comfortable with. So after that, you check the patient profile. Go ahead with the easy cases first. The ones who are BPL, the ones who are free cases, charity cases, go ahead with them first and then only move on to the demanding and the VIP cases. So again, select the right case. Simple cases, single break, fresh RD, less PVR changes, select them first. As you move on, you will be able to do the more complex ones. So initially just avoid the advanced PVR ones. Then preoperatively, you have to plan very well. You have to gauge whether you have everything available to manage the case, from instrumentation to visualization, raw materials. Take a proper consent in the language of the patient. Proper documentation is very important from pre-op, intra-op to post-op. So salient points in the history is the duration of the symptoms. It's very important to know for how long the patient has not been seeing well. If he's not been seeing well for a long time, that means a long-standing RD, and you may not have a good visual outcome. In case of macula on RD, a patient presents to you with flashes, you have to have a high index of suspicion while examining the patient. Again, any history of any preceding trauma or intraocular surgery which has led to the RD is to be known. History of amblyopia preoperatively itself will lead to the visual outcome worsening. Again, systemic history of diabetes, hypertension, heart disease, any exposure to any addictions, tobacco, nicotine will affect the optic nerve function, again affecting your visual outcome. So you have to make a large diagram before the surgery. It has to be known whether the patient is phakic, aphakic, pseudophakic. Make a plan for the surgery, whether it is amenable to buccal or width, depending upon whether you can indent it well. Also prognosticate the patient in terms of visual as well as anatomical outcomes. Say so many % chances of the retina attaching in the first go. Fresh RD, it is 60%. Old RD is like 30 to 40%. Twice, thrice operated means 10% or maybe no chance to fix the RD. So anatomical outcome has to be given. Whether the vision will improve or remain the same, that also has to be known by the patient. So this is a kind of a large diagram. I'm not elaborating this. So you also have to know when to do encirclage. So to begin with, beginners, I think they should do encirclage in almost every case, because the thing is that you are not able to do a good base excision. Since you're a beginner, you're not able to go so close to the retina. So better to do a encirclage so that the base is supported and you can also see it for the rest of the surgery. Again, multiple break, pseudophakic RD with peripheral thick capsular rim, phakic RD where base excision is not so much possible. If it's a young patient, again PVR changes are, PVD cannot be induced till the periphery. Then peripheral PVR changes. So all this needs a support. One-eyed patient, even if you are very experienced, please put a buckle so that the base is supported and you have double chances of the retina surviving. Visualization. This is the first and foremost thing. A fresh fellow has a problem. He will, from the eye of the surgeon to the eye of the patient, there are so many interfaces. If there is any obstruction in any of these interfaces, any fogging anywhere, you're not able to see. So you have to address this. First thing, put a tape on your mask. If you're wearing spectacles, you will have fogging on your spectacles first. Again, there are these anti-fogging wipes that have come. So clean all the lens surfaces, whichever you can see, clean with that, so the mist will not fix on them. Again, there is this wrench. Some people have a wrench, some people have a side tray. You put a drape on that, so the air coming out from the nostrils of the patient does not fog any of your lenses. Again, a gauze piece at the lateral canthus will help drain any fluid which is put during the surgery. And a cotton pellet, wet cotton pellet at the nasal, medial canthus. It will help avoid fogging from the patient's nostril. Position of the head. It has to be parallel to the wide field lens. And slightly you can tilt the chin up by 10 degrees. Temperature and humidity has to be low, like 16 to 18 degrees Celsius temperature and humidity less than 40. Position of the ports. The position of the ports actually you know that it is SNQ, STQ and INQ. But in case of a retinal detachment surgery, it is better to be more close to the horizontal, so there is more maneuverability while you're doing the surgery. Now again, before starting the surgery, check your IPD, check where the bed height foot switch is, check whether your microscope foot switch, where the magnification increase, decrease, depth increase or decrease. You have to check before that, and check the ergonomics. Your back should be straight, you should be comfortably seated before starting the surgery. First thing that I do is increase the magnification to the maximum. Then I focus at the limbus vessels. Then after that, I will bring it back to a level where all three sclerotomies are focused. After that, I will again take the light pipe inside, focus it to the maximum, bring the maximum magnification once more. Now I focus the disc. Then I decrease the magnification again, so that the entire retina is focused in one image. So during the entire surgery, now I don't have to move. The whole retina is going to be focused in one. Okay, so I'll actually move to the video. 1 second. So you can see this. I am starting with the sclerotomies. Okay, first thing is when you put the infusion, you have to check whether it is in. The most common mistake that we do is, we have put the infusion, we don't check, we switch it on, and it may be subretinal, it may be suprachoroidal, and we have ruined the surgery. Okay, this is the first thing. Next is now you see I'm checking with my light pipe. I've switched off the microscope. Okay, now I'm putting the other two sclerotomies, and we start the vitrectomy after this. Yeah, see I have, 1 second, I pause. 1 second, 1 second. Just see that I brought the magnification to the highest. I wanted to discuss this, is okay? I'll take some more time. Yes. Yeah, so, this portion is very important. Yeah, see magnification I've taken to the highest, then I brought it back after focusing at the limbus vessel. Now inside also I have taken the maximum magnification, then I focus the disc vessels, then I bring back the magnification to a position when I can focus the entire retina now in one go. Now throughout the surgery I don't have to move the focus or the magnification. Now I have done the core vitrectomy, I am trying to induce the PVD. See, from the disc, we start the PVD induction. PVD induction is a very important step during the surgery. So, you have to take your cutter as close as possible to the disc, don't touch the disc, and take it nasally. And take it nasally along the vessels. And the highest vacuum has to be kept, like 580 to 600 also. Whatever you have the highest, you keep that. Bring your cutter closest to the disc and then press the vacuum to the highest and then drag it along the vessels without touching. So you will get a plane and the vitreous will get separated. If you don't, then you use a pick. You use a retinal pick. After that you do a good base excision. In this one I see that there was some more vitreous, then I have stained. Again this is helping us to improve the intraop visualization. See? The intraoperative visualization I am improving with tricot, triamcinolone. Okay. Now after that, it's very important to do a good base excision after this. In base excision what we do is, that in the periphery, while we are going close to the retina, the vacuum has to be low, as low as possible. Sometimes even at 100, the retina keeps flapping in. So you have to keep it 50 or something. Okay. And after that, when you are inducing your PVD, when you go close to the primary break, as you've gone close to the primary break and you've removed the hyaloid on top of it, then the subretinal fluid automatically starts flowing. See, it has automatically started flowing, subretinal fluid. After this, you will do the FGE or fluid gas exchange. Okay. One more thing, while you're going around, you have to mark the break. This is diathermy. I have marked the break. So in this surgery, I didn't get any iatrogenic breaks. But as soon as you get the breaks, keep marking them with your diathermy. Otherwise, you might forget, and after FG, you can't visualize. So now FG is being done. You see that my flute needle is at the primary break, and this bubble is slowly filling up the entire retina. As you go to the peripheral break first, okay, then the nearer ones, like from periphery to center, you have to move. The furthermost break you have to go first. As the fluid keeps coming to the center, you move on to the central break. And last of all, you have to move to the disc. So disc, keep alternating with the peripheral break. After this, you have to do the laser. Laser the breaks first and then the periphery 360 degrees. So before this, our speaker did say that he doesn't prefer to do 360 degree laser. But for beginners, please go ahead and do 360 degree laser, because you don't know what you missed. If you have done a iatrogenic break somewhere in the periphery you didn't see, it's better to laser it off. Last of all, this silicone oil injection. You see that I am injecting till my globe is 3/4 full. I'll keep visualizing. Once 3/4 filling is over, I will put a vent. Till it comes out of this vent, I will wait. Now it has come out and surgery is over. And you have to remove the last bubble with your flute. Sorry I took time because nobody is there, so I took time.
It's okay.
Yeah, thank you so much.
Thank you. Very nice tips for the beginner. Only 1-2 point I want to add to her talk. One is whenever you are inserting irrigation probe, that is very important. You check the tip, ensure that it is inside your vitreous cavity. So either you depress and see the shining tip, that is very important, because if you suspect in some cases your 4 mm cannula may not be sufficient, then 6 mm cannula
6
use.
mm cannula.
Or if it is too bullous, not necessarily the same, you can choose other area also. And if it is very huge bullous, then obviously you have to drain fluid first. Otherwise 6 mm cannula is sufficient, or you may choose some other location. That is one tip. Second, rightly madam told at the end of surgery, always check the peripheral part, and especially the insertion site of the probe. Check that, and if you suspect some anything, try to do his laser. So it is a very good tip. Thank you, Dr. Vandana.
Last of all, we should pack everything like this in the end, because you will need them again. If you are a beginner, you will be in a setup where nobody is helping you. You have to pack and keep so that you can ETO it or plasma sterilize.
Thank you, Dr. Vandana, for a very nice talk.
Yeah, thank you.
Our next speaker is Dr. Priyadarshi Gupta, the art and science of scleral buccal surgery. Is he here? No? Okay, so this is the last day, that's why. Okay, our last speaker is Dr. Asnit Sandhu. She will talk about our experience of pneumatic retinopexy in rhegmatogenous retinal detachment. Dr. Bandana, are you going, or you can join here, please? Please join.
Good afternoon, everyone. I'll be talking about our experience of pneumatic retinopexy and rhegmatogenous retinal detachment. So what basically is pneumatic retinopexy? It basically involves sealing of the retinal breaks with introduction of an intraocular gas bubble, which remains long enough so that the subretinal fluid is absorbed and the chorioretinal adhesion occurs around the causative break or the tear. So it has been demonstrated that the rates of final reattachment were comparable to those of scleral buccal and pars plana vitrectomy. So it's an outpatient procedure with comparatively less complications. So the aim of a study was to see the visual recovery in patients and to assess the success rate following pneumatic retinopexy. So 25 patients were taken over a period of 6 months, and the patients who were eligible for pneumatic retinopexy were those who had a single or a multiple contiguous breaks which were positioned from 8 to 4 clock hours. And we need to keep in mind that, that a clear optical media is very important for a good retinal examination. The patients who were excluded were those who had a lattice degeneration outside the quadrants, usually the inferior breaks or inferior lattices, who had PVR changes of grade C or more, and who were unable to maintain a post-operative head positioning, and known cases of glaucoma. So the technique, it was a one-session procedure with informed consents were taken from all the patients. A peribulbar block of 2% xylocaine was given. The eye was cleaned. The cryoprexy around the retinal holes were done. An anterior chamber translimbal paracentesis was done, and 0.6 ml of SF6 was injected. After the injection, a chorioretinal perfusion is very important to be checked, and the patient is counseled about the positioning of the head. That is, the supine position should be maintained for a minimum duration of 6 hours post-surgery, and thereafter how long he can maintain it. So these patients were followed up on day 1, 3, 5, and 15, and later monthly follow-ups were done for 3 months and 3 monthly for 6 months. So on every visit, the visual acuity, intraocular pressure, and a retinal examination by indirect ophthalmoscopy was done. All the patients were administered Diamox for 2 days post-surgery, and wherever needed, retinal laser by AIOCMT3 was done, usually on day 3. So the fundus diagram is very important to be made in all the patients by indirect ophthalmoscopy. So this is a patient which is showing a left eye. There is a horseshoe tear present, resulting in a retinal detachment. So another patient had a lattice with an horseshoe tear, resulting in again a bullous rhegmatogenous retinal detachment. So there was another patient who had a coloboma and he had a horseshoe tear which was present. Again, pneumatic retinopexy was done and the results were achieved. There was also a patient who had a giant retinal tear and he had a very shallow RD. So we went ahead and did a pneumatic retinopexy, and the results were good in this case also. So talking about the results, the mean age which was seen was 47 years, ranging from 21 to 78 years. Most of the patients were male. Right eye was most commonly involved in these patients. Most of the patients which taken up for surgery were, for pneumatic retinopexy, were phakic patients. And they had an extent of retinal detachment. Most of them were between 3 to 4 clock hours, that's 36%. And majority again had a macula-on retinal detachment. So the number of retinal tears usually in such patients, there were horseshoe tear, which was usually involving only a single tear was present, which resulted in a rhegmatogenous retinal detachment. So the visual acuity which was seen was on post-op day after 2 weeks. It was seen that 60% showed an improvement in at least 2 Snellen lines, and there were 8 eyes which had no significant improvement in the visual acuity. So the success rate which was seen was that 72% had a single operation success rate. The 5 cases required vitrectomy with silicone oil injection, and 2 cases underwent a belt buckle. They were usually the patient who had a prior implantable phakic contact lens inserted in them. So it was also seen that the phakic eyes had a better result than the pseudophakic eyes. Complications which were noted during our procedure was there were anterior chamber gas migration, subretinal gas migration, resulting in a retinal detachment in 28%. Similar results were also seen in the other studies which have been conducted in the past years. So to conclude, pneumatic retinopexy is a safe, low-cost, a well-tolerated outpatient procedure which is usually underutilized. Successful outcome is primarily dependent upon a thorough retinal examination, wherein we have to identify all the breaks with an indirect ophthalmoscopy. So the patient selection is very important before going ahead with pneumatic retinopexy, and it can be a first-line treatment and a non-surgical alternative to scleral buccal or pars plana vitrectomy in patients who have an uncomplicated superior rhegmatogenous retinal detachment. These were the references. Thank you.
Thank you. Obvious. So choosing for
The
retinopexy, the patient selection is very first and foremost criteria.
Patient selection.
So, what is your selection criteria?
Ma'am, usually they were young patients who did not have a proliferative retinopathy changes. PVR changes we have to exclude because that will usually result in the failure of the gas bubble. And another thing is the patients who had a superior, that's 8 to 4 clock hours, regmatogenous retinal detachment is important for the brakes to attach.
Obviously, because if you don't have a setup also initially, you can try this. If patient selection is good and patient is a good candidate, later on if you don't succeed, you can refer for surgery. But obviously, thank you.
Yes.
You can discuss something, Dr. Vandana also.
Very nice set of cases. Actually, I am interested in the one that you were talking about, the giant retinal tear.
Yes,
So you talked about
it
a
had
few.
it has a
did-
very shallow regmatogenous retinal
So
detachment.
was it successful
It
later
was
on?
successful. The patient's vision improved.
So which were the ones that you said that like few of them, no, that failed, like it's
They were usually, ma'am, patients who were mostly old age, unable to maintain a post-operative head positioning, although they were counseled, because there was 2 patients who were above 70, but because it's a low-cost procedure, they could not pay well, and they did not want to undergo the exclusive surgery, so we had gone ahead and done the pneumatic retinopexy, but it failed, so we again went ahead and did a pars vitrectomy for them.
okay. Thanks.
Thank
you. Very nice.
Thank you.
Thank you. Any speaker joined later, or we will conclude the session? I don't think anybody joined. So, may I call if whoever is present for a group photo, then we can leave all. Thank you.